Welcome everyone to today's webinar on artificial intelligence in healthcare, based on Chilmark Research's latest report, The Promise of AI and ML in Healthcare: Opportunities, Challenges, and Vendor Landscape. I'm Hannah Enley, Chilmark's Marketing Manager and today's webinar moderator. Before we begin, I should note we are recording this webinar and will include it in our follow-up email. If you have any questions during the presentation or discussion, please submit them via the Questions tab in the GoToWebinar panel next to the presentation screen. We will address them at the end of the webinar as part of the discussion. Next, I'd like to introduce Chilmark Research. We are an analyst firm dedicated to helping organizations deploy and use IT to improve healthcare delivery through our objective, high-quality research and advice. Today's presenter is Senior Analyst Jody Rank. Jody leads Chilmark's research on artificial intelligence, machine learning, blockchain, and precision medicine technologies, as well as population health management strategies around the world. With that, Jody, would you like to tell us about applications and challenges for AI in healthcare?
Sure. Thank you, Hannah, and good afternoon or good morning, depending on where you are. So today we're going to be going through our recent report on opportunities, challenges in the vendor landscape in AI in healthcare. And some of the themes that we'll be touching on range from the underlying trends and drivers to some of the challenges. And overall, the report that we're doing is a broad scan of the whole universe of the various verticals within healthcare and who's doing what. In the report, we covered about 120 different companies, or nearly 120 different companies across the main verticals. And those include business operations, population health management, clinical decision support, what the EHRs are doing, and then patient-facing applications. And we also discussed a number of the challenges with around data governance, ethical challenges, validation of algorithms, and so forth. So I'm going to begin, for those who may not be as familiar with the whole AI or especially machine learning universe, just a very, very brief overview of the different types of machine learning. And so in this diagram, we have the taxonomy of different types of machine learning, where we have supervised learning and unsupervised learning are the most commonly used approaches, where unsupervised learning works on data that have not already been labeled, and it's used when you actually have some kind of ground truth to work from and an idea of what your outputs will be. And a common application is classification. So we see this a lot in image recognition, things like that. Unsupervised learning is used when you have a set of data where you need to infer what the structure relationships around various features in that data set are like. And we see examples of using clustering and exploratory analysis, where you can begin to create some kind of hypothesis about the sort of underlying nature of that data and explore that more deeply to understand the population. And then finally, reinforcement learning is found most commonly in gaming and robotics. And this is when you have a very large environment and you're addressing sort of long-term rewards versus short-term options. And there's not as much being done in healthcare, but we're beginning to see a lot of interesting academic papers where this could be applied in creating better therapeutic options and so forth for patients. And why AI now? It's driven by a number of very obvious trends that have happened with overall digitalization of healthcare over the last decade, where we have a much higher volume of data, a much wider range of sources, everything from people's wearables, the EHRs, social determinants, and so forth. And AI provides us a way to understand relationships in that data, and as well as also automate a lot of business functions in healthcare, where we're still using a lot of manual methods and so forth. And we've also seen some of the technological shifts with capacity in central processing units and graphic processing units that enabled us to handle much higher volumes of data, and gradually bringing down the costs associated with that. We also have a lot of unstructured data in healthcare, so natural language processing is proving to be a very useful tool in that front to sort through that sort of 80% of the data in EHRs, for example, is unstructured data that is quite valuable for clinical decisions. And then it's interesting to note on this broader digitalization of the economy, how in a recent World Intellectual Property Organization study on AI, they noted that over half of the overall AI patents in the history of AI had been awarded since 2013. And the ratio of theory to sort of applied or invention, actual inventions based on AI, moved from an 8-to-1 ratio of theory to application in 2010 to 3-to-1 by 2016. And then machine learning has accounted for a third of all patents, and the life sciences and healthcare rank third overall in sectors of the economy where AI is being applied. Early on in the sort of the adoption of AI in healthcare, we saw players like IBM Watson, whose initial focus was on oncology. The early adoption, it was a bit rocky, but even now we're seeing after that getting off to a fairly rough start. IBM now has, in the last year or two, has dramatically improved the work that the applications that they're rolling out in oncology and other spaces. In addition to that, we saw a lot of the early work being done in dermatology and radiology, for example, because of the rise of deep learning and image classification matured much faster than some of the other application areas. And then by around 2016 or so, we saw a lot of interesting work on cardiology with Mayo Clinic, AliveCor, and Arteris, which was one of the first companies to actually get an FDA clearance. So now, after that sort of just brief history overview of AI in general, we're going to start diving into some of the application areas that we focused on in our report. And the first one is the business and hospital operations. And in this area, we looked at who's doing what in terms of revenue cycle management, payment integrity and fraud, hospital operations, and supply chain. And we see this is one of the areas that has the most rapid growth and is more mature than most of the other areas. First off, it's, you're not dealing as much with on the clinical side and the regulatory barriers, but there's also a lot of room for innovation to happen when you can take a lot of manual processes and the volume of data that we have around transactions and claims and so forth, and alleviate some of the work burden or automate some of these functions. Prior authorizations are a very important area given the growing burden they have for payers and providers, because of the fact that errors account for significant revenue leakage and delays. And the unwieldy sorts of manual methods in prior authorizations cost about $50 to $100 per individual case. So this is an area where there's a lot of room to automate and reduce costs. One of the companies we look at in this area is Change Healthcare, that embeds AI into all three of their main business areas, from financial, clinical, and engagement solutions. And they're trying to replace manual coding with AI coding that can result in fewer errors. And they've developed a tool called the Claims Lifecycle AI Service, which leverages data from over 2,200 payers, 5,500 health systems and hospitals, and over 900,000 physicians to improve payment accuracy, reduce denials, and enable better forecasting and reduce overhead costs for providers. Another area that's interesting is the issue of fraud, and using machine learning tools that can detect sort of outliers or types of patterns that could be indicative or predictive of fraud. So one of the examples we cover is Fraud Scope, which was spun out of the Georgia Institute of Technology, where this application does is it mines claim data and data from healthcare facilities, and they've developed an opioid abuse application that can also monitor pharmacy activities. And it's the users that they're designing for are the special investigation units, and it helps them to rapidly identify potential fraud and, for example, locations of phantom clinics directly in the application. And they've worked to really sort of integrate the tool within the workflows of these special investigation units. And then LexisNexis, for quite a while, they've been looking at public data and looking for patterns where, for example, you could see outlier things where users of a particular clinic were in a low income neighborhood, but everybody's driving a Mercedes-Benz, for example. So there could be something going on in collusion with a provider, for example, and finding these sort of outlier patterns. It could be where something is a bit out of whack, that it could be a predictor of fraud. In the supply chain space, Johns Hopkins University Medical Hospital has worked with GE Healthcare partners to come up with a tool that helps create efficiencies in how patients are assigned beds. And this was a task that had been previously assigned to over 50 different bed managers. And the tool has been found to help them assign beds 30% faster, with an 80% cut in the need to keep patients in recovery rooms longer. It'll be interesting to follow some of the examples like this as we are in the middle of the coronavirus pandemic, and how these tools function under these extreme conditions, and if they are actually able to in any way address some of the challenges hospitals are facing. CloudFace is another company we covered in the supply chain front, and it's an interesting example where they've been in their first implementation at Loma Linda Hospital a while back. They were able to integrate 4,000 to 5,000 disparate software systems in the hospital supply chain, and get sort of a bird's eye analytical view of the entire supply chain. And within 6 months, they were able to cut $100 million of excess cost for things like double billing for knee replacements, for example. But in addition, they actually proved health outcomes by finding patterns around staph infections, where the doctor's neckties, they discovered, were when the doctor would be at the patient bedside, occasionally the neckties would touch the sheets, and they would take staph to the next patient's bed that they encountered. And as well as the laundry service of the hospital one of them was not getting the temperature high enough, and therefore not killing the staph infection. They were able to see this through this sort of bird's eye view of the analytics. And the other interesting aspect is it's a cybersecurity / cloud-based company. So it also locks down, creates the supply, it locks down the vulnerabilities at the ends of the supply chain, where hackers often snake their way through the ransomware can take over. The next area we look at is clinical decision support, and this is an area that gets a lot of attention in the media, and sort of the predictive possibilities, but we still find this is not nearly as mature as what we find in the business operations end of the spectrum of applications. And in the clinical decision support, we look at clinical documentation, medical imaging, pathology, and point of care CDS. And here, some of the examples we look at include Google's DeepMind Health, which has been used in the UK National Health Service to mine health records for faster detection of eye diseases, faster development of radiotherapy protocols, and detection of early warning signs of patient deterioration from the EHR data. And in the last 6 months or so, they also launched their Streams AI application, which is a mobile app for doctors and nurses that's used at the Royal Free London Trust and Imperial College Healthcare Trust. And there have also been some issues around, that came up with some of the ethical issues around access to large patient data sets. That's still an ongoing issue that we'll address later on in this report. We address throughout or this presentation, and in the report we look at what's going on in that area around how are we going to protect patient privacy as well as security, data security, as the scale of some of these ventures grows. IBM Watson Health is a major player in this area as well, and they've developed their merged platform that includes MRI visualizations, cardiology, hematology, radiology, and orthopedics. Gives a clinical review and extraction of patient information from the EHRs. And they've been working to develop, they're integrating both structured and unstructured data, and a number of tools that help clinicians stay in line with the federal guidelines in whatever national context they're working in, as well as a strong focus on ways to decrease patient burnout. And quite a bit of work in the radiology space with their Care Advisor application, for example, that supports radiologists in making the best diagnosis and coming up with treatment plans for the patient. It's important to note they have been doing quite a bit of research looking at the effects and outcomes associated with this. They've come out in the last 6 months and ongoing I encourage you to take a look at some of those, and we have references to them in the paper. We also look at Nuance and 3M, which are both using speech recognition for computer-assisted physician documentation that, on one hand, helps improve reimbursement and outcomes, as well as sort of the patient encounter with the physician, and using speech recognition that can sort of improve that patient-physician interaction. But these tools also play a very important role in reducing error rates for reimbursement applications and so forth. And they both use natural language processing as well. And the next area we look at was the EHR space and what the major EHR vendors are doing in this area. And these covered everything from the clinical documentation, voice assistance, the CDS, diagnostics and predictive analytics, and data extraction. And one of the most important vendor we looked at here is the largest, being Epic, which initially focused on natural language processing and voice recognition for clinical documentation. And they've also have their cognitive computing platform built on Microsoft Azure that has analytics and AI for clinical workflows, correction of documentation errors, and a decision support application. They've also begun work with integrating social determinants into the EHR analytics for better predictive models and closing care gaps. And then their all of these are using their Cosmos database that has over 200 million de-identified patient records, which they're currently focused on using for building machine learning-based models that can optimize treatment plans for better outcomes. Next area we look at is population health management. And there are 3 main subheadings we looked at in the report that cover everything from risk stratification, population care management, and patient engagement. And some of the companies we looked at in this area, this obviously the data analytics for overall population health management. So we looked at, for example, Health Catalyst, which has developed Catalyst.ai as an open source tool for integrating AI into their PHM tools for readmissions reductions, for reducing hospital-acquired infections, predictive models for chronic diseases, models for propensity to pay, and predicting no-shows for appointments, just to name a few of the applications. When we interviewed them, it was interesting how they're approaching sort of the scaling up of their machine learning work, and recognizing early on that the population that they base the initial model on may have issues when you apply that beyond that initial population, what we call distribution shift, where other populations may have slightly different features, and there's a need to work closely with the clinicians on the ground to understand what the models, sort of the outputs of the model, and then go back and often tweak that model for different populations. So it's a good example. They're doing a very good job of bridging that human computer interaction with AI and this issue around distribution shift. Another company we looked at is Javion. It focuses on predictive analytics for preventable harm and works by identifying at-risk patients and possible readmission trajectories given any given patient's risk factors. I initially based the analytics on a data set of 16 million and focused on the top 50 most preventable harm vectors that are trajectories where interventions could change the ultimate trajectory towards that outcome. And I believe now they're up to over 30 million patient records in their data set. And interestingly, in the last week or two, they've launched a COVID application that's useful for kind of community level risk analysis for prevention and access to care. Prealize, which is a formerly Cardinal Analytics solution, is also working with Optum in Virginia to bridge risk stratification and population health management, and in their work to provide stronger risk models that have both clinical impactability and higher levels of engagement around those risk issues to drive better outcomes. And one of the more interesting examples of natural language processing we came across was CliniThink, that enables physicians to search the unstructured data and records, which can be based on SNOMED. 80% of the data needs of clinicians are often found in that unstructured data. And using the CliniThink tools, clinicians are able to get summaries in a very rapid, easy manner that can also connect these summaries into their needs in revenue cycle management and filling in the gaps and clarifying codes that can help reduce denials. One of the other companies we look at is Conversa, which is also more in the patient-facing side in their use of bots to help patients understand everything from symptoms, insurers, and they've also recently come up with a COVID application as well, I believe. The final area that we look at is in clinical research, drug development, and discovery. Here we look at precision medicine, clinical trials, drug discovery, and basic research. And in this broader area, we see applications that range from, in the drug discovery, working with pharmaceutical companies to model either the genomics, physiology, discovering the right molecules that could be appropriate for it, or potential molecules for drug candidates, to matching patients with appropriate clinical trials, and then speeding up the entrance into clinical trials where a lot of time has been wasted or gets lost in aggregating all of their clinical data and then enrolling them in the trial, in addition to matching them, and so forth, which is also an important application of a lot of the precision medicine tools as well. And this is also another area where Watson Health Oncology is, this is where they're doing a lot of studies that address the federal guidelines, treatment plans, and clinical trials, and how, they're publishing a study on how the IBM Watson Health Oncology tool can now perform as well or better than manual assessment of tumors in this oncology application. Flatiron Health is another prominent player in the precision medicine space. Utilizes cloud computing and AI to mine EHRs, and they have an entire suite of applications for providers that manages everything from billing to EHR analytics and clinical trial matching. And their oncology care model, when we were writing the report last fall, had at least 200 oncology practices and 16 payers where they've used the data across that population to customize care coordination and build patient navigation tools for patients seeking cancer care. They also have applications in the life sciences and for biopharma clients where they utilize real-world evidence analytics based on the mining of EHR phenotype data that can help for drug development and discovery. Concerto Health AI is another company we focused on that utilizes real-world data and AI for biopharma provider clients. Their platform's called Eureka Health, and it's working very closely with the American Society of Clinical Oncology's CancerLink repository. And from that data, they've developed a model for predicting lung cancer patient survival, and also help clinical development teams select attributes for pre and post-approval studies. And they have also have a provider solution that generates data on clinical variability and is integrated into their clinical workflows. On the patient-facing side, they look at broad spectrum of applications that cover everything from chatbots and symptom checkers to laboratory testing, substance abuse and mental health, voice assistants, and then applications running on top of wearables. One of the more interesting applications I discovered here doing the research was in the substance abuse area, where their dynamic, a good example is Dynamic Care Health. They have a platform that integrates AI tools, sensors, and mobile devices, and behavioral incentives to do sort of remote monitoring of many of the tasks involved with substance abuse. So they use facial recognition in a mobile app to identify a patient remotely, and then a variety of Bluetooth devices from breathalyzers and other devices that can monitor whether the patient is, or the user's compliant with the substance abuse regimen they're on. So a provider can check in on a patient, verify them, and then do a spot check. And this is without the need for the person enrolled in the program to show up at a different clinical site and provide biospecimens, for example. So they can do this remotely, and then they have a sort of a type of population health management dashboard where the provider can cover a population of patients, do check-ins, and also, use call nurses and so forth when needed to do face-to-face or follow-up care. And then they also have an incentive program where friends and family of users can give these gift cards that can only be used for food. It can't be used for, obviously, alcohol and other products. But as long as they're compliant, you can reward the user for checking in and using the app and being compliant with their regimen. So it's a very kind of more holistic use where AI is used in both facial recognition and the data analytics. Then there's the well-known Babylon Health, which has created an interactive symptom checker or chatbot called Health Check that helps patients get information on their condition management, as well as a virtual care mobile application. And they've built this knowledge graph. It's considered one of the world's largest structured medical knowledge databases that allows them to derive insights from the data collected around symptoms and outcomes. And it's been used globally, everywhere from UK, Canada, Asia, Rwanda, and some of the private sector clients of TELUS Health. This also includes great deal of work being done with Amazon Alexa. And one example is the KidsMD application that was developed in collaboration with Boston Children's Hospital. And they're now testing over 60 different voice assistant applications. And Amazon has also developed a partnership with the UK National Health System to extract information from the NHS website that can be used to answer health-related questions. And then another interesting aspect of that work is also targeting the elderly and the blind who may have limited internet access or sight impairments and so forth to use the voice instead. Mayo Clinic is also another player in this space that is doing a lot of work with voice assistant applications, and they have a first aid application, and they're doing some interesting research on using the voice assistant as a sort of a diagnostic for cardiovascular disease. And there's some emerging research that is using the different characteristics in the voice and how that can be predictive of the onset of different conditions. But I think we're still quite early into seeing how that is actually going to work out. In the wearable space, we see a lot, everybody's familiar with the Apple Watch and the ECG, which there's a lot of research going into AFib and other different heart conditions, research with Stanford Medical School, AliveCore's ECG band as well, and CardioCore. One of the more interesting players in this space is PhysIQ, which is a platform that can integrate all the data from a wide range of wearables and extract insights for actionable intelligence to providers. And they also just announced, I think this morning, that they're just got FDA clearance, and their goal is to use the platform now with some of these drug trials for coronavirus treatments as well. That gives you a bit of a taste for some of the vendors and areas that we explore in the report. Now we'll go to some of the trends and where we see the market going. This graphic is a bit hard to read, but I think it gives you some idea of the magnitude of patents that have been issued, or FDA, not patents, but FDA clearances for AI-based algorithms in medicine over the last year or so. And we counted at the end of last year roughly 40 new FDA clearances over the last year, and I believe that was up from 12 the year before. So we're seeing, a great deal of activity in that area. And then very recently, FDA issued some initial guidelines, which we have been blogging about at Chilmark, and we have some forthcoming work on everything from explainability of algorithms, so forth, but we do touch that briefly in this report. We can talk about that more. In terms of the overall maturity, it was mentioned before, we see the most mature applications are in the operations administrative side and imaging, and then clinical decision support and research are much more in the earlier stages than those, but we're still overall in the early days of AI, machine learning in healthcare. In order for this to move forward in any significant way, we look at some of the challenges that need to be overcome. And one of the big areas, I think, goes back to the fundamental difference of AI machine learning tools from software in general that we're accustomed to using in health IT and elsewhere, where in contrast to the software of the past that we used, machine learning and AI are tools that we assess them based on probabilities. It's just like almost like a diagnostic with sensitivity and specificity, at least in the clinical side. So they have error rates that we have to deal with, and we're dealing with statistical tools. And statistical tools, on one hand, need to have a certain level of reliability or validity, but then beyond that, they're being rolled out into a broader context where they have impacts on clinical workflows, possible redundancies, and so forth. So it's a bit more complex in some ways than or different from traditional software. And so in the report, we look at a proposed model for assessing the various layers of validity of machine learning tools, and it begins with the statistical validity. It will cover the overall accuracy, sensitivity, positive predictive value, or what technically is referred to as the area under the receiver operating characteristic, or ROC. So this assesses how that model or algorithm performed on a specific population data set. And then with that, you also have to look at how that model will perform on other population data sets in the future as it moves from the training set and beyond, which we referred to before around this distribution shift. But beyond the statistical validity, we also have issues of relational validity. It looks whether physicians or other users can actually relate to the AI and attach clinical meaning to the actual outputs, and then how easily that's integrated into their workflows. So what we're seeing is the smarter players in this space from the outset, in addition to the statistical validity and their classical data science, they're also working with the end users up front. That can also help you understand biases, things that are going to get in the way downstream where things can go drastically wrong, possibly. But this relational validity also means assessing the overall security of the system, efficiency, and user satisfaction. And then as we move beyond the sort of relational validity, with that we get into that, these efficiencies and cost savings and a reduced amount of paperwork and so forth for these end users. And then, even to the point of patient-reported outcomes. Then we start looking at the ecological validity of the tool. And this is where this is why, in the early stages, these questions around validity are asking questions that we need to ask about this that may be able to surface some of the obstacles that are getting in the way. And so the ecological validity looks at the overall context, social context, beyond strictly clinical and workflow or productivity areas, and look at the social impact this tool is going to have on careers, and such as certifications and guidelines and rights-related laws. There's a lot of open question marks around, with a machine learning tool, how will medical tort law respond when the algorithm can work autonomously? Who's responsible when things go wrong? So then once we get beyond this broader kind of social or ecological validity, how replicable and sustainable is this going to be? If the literature changes very quickly, how quickly does the model respond to that? There's some work showing that the average half-life of medical data for some conditions is 4 months or less. So there's going to be a lot of work required in sustaining AI tools. So as we get, these are just a smattering of some of the issues we cover in the report, everything from the data exchange and sharing in getting access to enough data to train the algorithms, where we, in the startup part segment of the ecosystem, you're basically having a world emerge where we have sort of data haves and have-nots. And the companies, you can have the world's best data scientists, but if you don't have access to the good data, you're only going to go so far. And so we do expect there could be some winnowing out of startups in this space, given that issue. The issue of privacy, security, and trust. People, as we mentioned, that these validity issues get to getting the buy-in from end users, and do they trust the models that are being used? Are they finding outputs from these systems that they can rely on? And do they understand where how these models actually work? And that's also an issue that we're going to have for issues like patient consent. If the provider does not understand how the AI system works, how are they going to convey to a patient how a diagnostic tool, for example, works? So that issue of explainability is an important one, just even in that clinical encounter and from an ethical standpoint. There are also issues around bias that are tremendous across the AI and machine learning, at least a huge amount of discussion in the field itself. In healthcare, we have the historical legacy of the exclusion of women, children, a lot of minority populations from clinical trials that we're dealing with sort of legacy data that we're dealing with in many cases. There's also Stat ran an article last summer on a very large number of models or algorithms developed in the AI work in healthcare are based on the MIMIC data set, which is a set of 46,000 de-identified medical records from Boston's Beth Israel Deaconess Medical Center. And since 2009, as of last summer, over 12,000 researchers had used this data set to train algorithms on. And it's one of the only free data sets that's really has the labeling details needed for AI. So in effect, the way ImageNet became the primary database used for development of deep learning tools for image recognition, the MIMIC data set has a parallel issue in healthcare AI. So we have to ask, even though that data set is a fairly diverse population, it may have, that population in the Boston area may have different features, for example, than an equivalent sized data set in Mississippi or Florida. And so you're always going to have to address that distribution shift that happens around the different features in new populations. So there are some other similar examples of kind of over-reliance on data sets that are easy to use and that need to understand whatever the potential bias is going to emerge from that. And this raises the broader point of how the underlying ethics of your AI need to be baked in from the start. Accenture, Runman Chaudhary has referred to the ethical debt that companies have, where if they do not bake their ethics and work on bias and so forth into their applications from the start, that could have a very large reputational risk downstream. So this is an area that Chilmark we've been focused quite a bit on. And then there's the issue of cybersecurity. The more we share data, the greater the risks are. So in this sort of AI is a data hungry endeavor. So we're seeing more and more partnerships form where organizations may share data on a joint venture to develop the algorithm. So what's being done to protect the privacy and the privacy of individuals and security of the data? And so we cover things in our report, and we've been doing this in our domain monitors for those of you who subscribe to Chilmark. A lot of work in the area of federated learning, which enables differential privacy, which enables using sort of a model that can be applied on your individual data without sharing that data and then sharing those models back to a central player. So it's kind of decentralized centralization in a way. And companies such as Leapfrog.io that uses a differential privacy platform that also accomplishes a similar type of function. Approximately, it's also estimated that about 80% of all the work done to develop an AI system in healthcare is just curating, labeling, cleaning the data, and so forth. So the tasks involved with preparing data to be used for an AI machine learning application in healthcare is rather immense, the amount of work that goes into that aspect. So we have some focus on that. And our next report, we're going to be looking at building a model around data governance and preparation of data and the data governance that's involved with that as well. And also already mentioned security. So as we go forward, some of the trends, I've already mentioned the issue around federated learning. There's also, I'm going to first address that one of the big trends that's going to shape the future of machine learning, AI in healthcare is obviously the entry of the broader, the largest platform players from Amazon, Microsoft, and Google into healthcare with their combination of AI and the cloud, bringing into the market very rapidly their AI analytics offerings. Microsoft Health, which was launched in 2018, is working to improve health record sharing and interoperability using the Azure API. And they've also launched the Microsoft Healthcare Bot. Google Cloud's Healthcare API can be configured with TensorFlow, and their cloud machine learning engine is being rolled out for PHM applications. And we've seen the sort of controversial partnership with Ascension and with Mayo Clinic. And interestingly there, with the Mayo Clinic, they use the federated learning that really addresses that privacy issue that popped up in the Ascension partnership. Amazon AWS offerings include their NLP engine. It's called the Amazon Comprehend Medical, Amazon SageMaker, and Ground Truth, which focuses on active learning for data labeling and processing with a particular focus on medical imaging. And SageMaker RL is using the reinforced learning for use where the prior data sets are either not feasible or prohibitively expensive to create a different road or path to building a model where accessing that data may be difficult. And so far, some of their tools are being used in GE Healthcare's MRI and X-ray devices. In our report, we estimated that about 25 to 30% of all the companies that we looked at were providing SaaS offerings. One of the issues is with AI solutions are a bit more complex to sell and implement than standard cloud offerings, given some of the data challenges. And these SaaS offerings can sit on top of existing CRMs and other business solutions and make it easier to implement. One of the interesting examples that we saw, it has a very interesting kind of enterprise level platform we hear less about, is John Snow Labs, which has a data integration, data science, and data exploration sort of platform that can be applied towards a pretty broad range of healthcare applications and is useful to look at. One of the big drawbacks in existing applications is the fact that the heavy reliance on deep learning, which is very valuable in finding and working with associations in data, but not very good at understanding causal models or addressing problems where causality is important, which is a lot of sort of clinical medicine and even our current situation, public health as well. And about a year and a half ago, 2 years ago, Judea Pearl came out with this book, The Book of Why, and that sparked a vigorous debate around, or not a debate, but intense interest in developing causal inference models. And we think this is an area to pay attention to. And you see a lot of work being done in various academic centers to develop the causal inference models. And we think these will have a lot more relevance down the road in areas, in the clinical side of healthcare, as well as, drug development and discovery. Some of the other things to look at that we're sort of tracking is these attempts to create data markets and algorithm markets that, number one, can address the need for high quality data, but on the other hand, address down the road as the field matures, the proliferation of models how can end users choose among those? So many of you may recall Apervita several years ago launching an algorithm market where the goal was to be able to try out different models on your data sets and see which models got the best outcomes or optimize your selection. So there you could see the sort of the beginnings of a world where we may historically have run one or two algorithms on a given data set for a given set of issues, but we'll be able to eventually have run 10, 12, 100 different models and then optimize which ones work best for any given data set. And so I think that algorithm model slash data or algorithm market slash data markets will be interesting to watch. And you do see some work around the genomic data markets in with like Nebula DNA, Luna DNA, Shiva, and so forth. And then I mentioned early on the issue of just the human and human interaction, working with the end users, and that and how there's a noticeable shift in how we're even talking about AI in terms of more on the augmented intelligence side. And so, working very early on so you can uncover the bias and then, deal with the distributional shift in algorithms. That's going to be incredibly important moving forward. And so all these notions of, replacing doctors and automating everything in the clinical side, we don't see that happening at all, but actually a stronger focus on the human dimensions and design will grow as this market matures. And with that, if you'd like to ask any questions, we can open it up for questions for the last few minutes.
Thank you, Jody. As you said, we're opening it up to questions. Feel free to submit your questions on the questions tab in the little control panel that should have popped up, and I will ask them as many as possible. To start, Jody, what are we seeing at the intersection of COVID-19 and AI so far?
So I've mentioned Javion's sort of social determinants, trying to find the barriers to care, the offering that they came out in the last week or two, and we've seen a similar type of thing with Heudia, which uses a lot of, in their software integrates a lot of GIS data, and actually have participatory research and GIS data that they've used all along, but now they're overlaying that with a coronavirus specific application to help you understand access and barriers to care, for example. From there, well, first I'll say, if you haven't looked at it by now, or the Chilmark Research blog, we have an area where the vendors can let us know what they're doing in this space, and we're keeping an ongoing tally of that. And in the next week or two, I plan to write a blog post sort of analyzing what we see to date. But beyond that, there's a lot of work going on around drug development and working with pharma to rapidly, as rapidly as possible, find potential drug candidates for coronavirus. We see a lot of work around modeling the epidemic. That's an area of a lot of vigorous discussion and debate, as well as imaging of CT scans for the diagnosis. In China, already have seen a paper to pop up on what they found and they're doing with that in China, because China's capacity to use CT scans is quite high. Other areas include outcome predictions, and as well as the infodemiology of, let's say, social media and the sort of bad information that's out there, and ridding systems of rumors and misinformation as well. And then some of the things that have popped up on the Chilmark Research blog already include a number of different symptom checkers that can help patients sort of self-assess and where to get information and go if they think they have coronavirus, and information on testing. So Ada Health, Conversa, Giant. BrightMD has been working on an evaluation screening tool with CDC. Cerner already has a screening, testing, and surveillance tools on top of the EHR. Curation Health has come out with some risk analytics for pre-existing conditions and profiles. So there's a lot of this, like sort of building another layer very quickly that's coronavirus specific, that can help understand risk factors that for serious complications. Health Catalyst is doing hotspot monitoring and tools for managing supply chains, and CloudFace is also very much focused on the supply chain issue. And Orion is also doing making some tools available for managing home health and a symptom checker. But these are just a smattering of the things we've seen to date.
Okay, one last question. Are you seeing any particular trends in end users wanting to consume pre-built AI ML models developed by vendors versus wanting to develop the models themselves in-house, given their potentially better access to robust data? So I guess the build versus buy conundrum?
Yeah. So that's a very good question. And I think in the pharma sector, I think you see a lot of vendors wanting to sell, and then biopharma sort of developing their own in-house data science teams. And so I think it's going to be like the really large players that can invest in the data science teams are building it in-house in general, and then smaller players, will go to some of these vendors, just as a very, very general. And I do think it's going to be interesting to see what happens in the biopharma space, where they've had the resources and they're building those in-house teams, and then there's quite a lot of startup work as well. That's going to be an interesting bellwether to see how that goes in the future, because there is some scarcity of data scientists, and having the resources to build out those teams when you have your own data to work from. So it's a bit early to tell, but I think that that pharma space is going to be an interesting one to watch and see how they do in-house versus buy elsewhere, buy from a startup.
Building on that, do you think the 21st Century Cures Act will help, or maybe not really impact or even hurt AI access to that needed data for building the most robust algorithms?
We didn't actually, I'm not sure yet. I need to think. I haven't had a chance to really think about that, but that's definitely an area we should, in the follow-on research that we plan on doing with our next report, is looking more at the maturation of the market, and that's going to be one of the drivers I want to dig much more deeply into in that report. So I don't have an answer yet, but stay tuned. In the next few months, we should have more thought on that.
Okay. Well, with that, I'm sorry we are at the end of our time. Thank you everyone for your questions, and I'm sorry we couldn't get to all of them. We'll follow up with you later. If you have additional questions, or you'd just like to follow up with Jody afterwards, please leave a comment in the follow-up survey right after we end, or email Jody directly. His email is on your screen. For more information on the applications and important issues for building and considerations for building and adopting AI tools for healthcare applications, I encourage you to check out our full report. The link is on your screen, and I will also include it in my follow-up email along with this slide deck and a recording of the presentation. I will also aim to include links to the various other pieces of content that from our blog or publicly available domain monitors that Jody mentioned throughout the presentation. Thank you, everyone, and stay safe, stay healthy. Bye-bye.